Hello and welcome to another masterclass on Bruxism, Snoring, and Apnea. I'm Professor Andrea Melo, a dentist for 19 years, a specialist in dental prosthetics and implants, post-graduated in periodontics with a master's in materials science from the Military Institute of Engineering, and a doctorate in dentistry from the State University of Rio de Janeiro, where I graduated. I'm a founding member of the International Society of Bruxism, but beyond any title, just like you, I'm in the chair every day with real patients facing the same challenges you might be facing. Patients with increasingly deep wear, patients with loss of vertical dimension of occlusion, patients with abfraction, cracks, fractures, loss of implants, screws loosening, unscrewing, failure after endodontics, crowns coming loose, and restorations fracturing. What I always strive for is treatments with longevity and predictability. And that's exactly why in this masterclass, I'll teach you how to become a reference in the fastest growing area in dentistry today. Bruxism, snoring, and apnea are happening right in your area, actually increasing your revenue with integrity and clinical authority. This can happen today in your clinical life, even if you don't charge for consultations or still accept health insurance. I'm going to show you and prove that we're living in a new phase, a new era of dentistry. And I know when you hear about a new era, about repositioning, it can seem very distant or even exaggerated. But if this transformation hadn't started first in my own clinic and then multiplied for thousands of students, dentists like you.
After I started applying Dr. Andrea Melo's methodology on bruxism, I felt much more confident in telling the patient that they have bruxism, and I feel like a reference because I'm always keeping myself updated, and offering better treatment options for my patients.
Like a light from God for me, because it was a completely different direction. Something I never expected could happen. I went from earning 8 raise, which was what I got for the first appointment through insurance, to 900 raise, which is the package I sell for the differential diagnosis of bruxism, and it includes all the steps of the diagnosis. And today, I'm a reference dentist for bruxism here, and I have security and confidence in my work, knowing that I'm doing the best for my patient.
Before I learned about Andrea's method, I used to just put up a little sign because that's all we had at the time. Now I'm reaching out to many of my former patients, bringing them back to my office with a new proposal for treating bruxism. I'm really excited about this. Currently, I consider myself an authority when it comes to solving these cases of bruxism. The symbol of a reference dentist is bruxism.
Method, right, from Dr. Andrea from DTIC, I started charging for consultations, and then I started to really take off. I'm super happy. I went from not charging for consultations to now. I charge 400 raise for the diagnostic splint, and for the complete differential diagnosis, I charge around 700 raise. And I'm closing treatment plans at around 2,500 raise. I've already taken my patients through the differential diagnosis treatment, and now I'm bringing some of them in for follow-up. But what makes me happiest, what really warms my heart, is being able to solve the patient's problem.
Everything I was doing was wrong. Today, I already approach the patient differently. I already feel confident showing them that I know what I'm doing, that I have mastered the content, and that I can give them my best. The diagnostic splint for me was honestly the biggest new thing I could have learned about bruxism. But like 90% of my clients are on health insurance, but they agreed to do the treatment. And the price I charge for the diagnostic splint is equivalent to what I would make seeing 8 health insurance patients. For me, this financial return has also been fundamental, and not to mention the value of the treatment as a whole, which we know doesn't just include the diagnostic splint. There are other steps, other pillars for treating bruxism.
Dentists like you who are in the chair every day, who have years of experience, their own practice, a full schedule, but who still didn't feel confident to actually diagnose, treat, and control bruxism, to understand their patient's snoring and apnea in a structured way with a step-by-step process from start to finish. Today, they've completely changed their clinical reality, and it wasn't because they learned another restorative or surgical technique or orthodontics. It was because they mastered a methodology that isn't on the market yet, in a clear and objective way, like I'm going to teach you. Clear method of differential diagnosis, treatment, and control of bruxism associated with apnea, bringing snoring into the dentist's reality because it's a complaint of many patients. And when you master the methodology, you gain something that money can't buy: confidence and authority by delivering health to your patient. Having predictability in treatments, sustaining rehabilitation and restorations with more longevity, being assertive, knowing what you're doing, reducing rework, saving more teeth, and improving your patient's quality of life, delivering real health as a healthcare professional, looking beyond the tube. And most importantly, you becoming a reference in your region. I know that many times you've dreamed of being a reference, and maybe that got lost along the way, but I want to tell you, the increase in revenue is a consequence. It will happen. Even if today you don't charge for that first consultation, even if you accept health insurance, even if you're a general practitioner, what I'll teach you in this masterclass will open your eye. You stop competing on price. You start being valued for your clinical reasoning, 360 degrees. And that's what the experienced dentist wants. He doesn't want to work more hours. He wants to work with more margin. You don't want to work with an overcrowded schedule where you can't give attention or deliver good work. You want to have predictability. You don't want to fight over price. You want to have authority. And this reality is also possible for you. Today, you're facing the biggest opportunity of the decade for us dentists. And maybe you're wondering, Andrea, how are bruxism, snoring, and apnea the biggest opportunity of the decade? Because it's the fastest growing area in Brazil and the world. Demand is massive, and we don't have enough qualified professionals available. Unfortunately, that's the reality. Bruxism won't decrease, snoring won't vanish, and apnea keeps growing. Prevalence is very high, bordering 30 to 40% of the population without a diagnosis. The patient has changed. They're more anxious, more medicated, sleeping poorly, breathing poorly, with bad habits, with a poor quality of life, and it shows in the teeth with early wear, appearing in younger and younger patients, with loss of vertical dimension of occlusion, airway collapse, children with anxiety and sleep bruxism, something we didn't see in the past. You didn't see children aged 4, 5, or 6 with as many problems as we see today. And most dentists are still only treating the wear, doing restorations, or giving out a mouth guard. When they treat it, if they look, and often they end up stalling the patient because they don't actually know how to solve it. There's a certain anxiety about seeing a patient with heavy wear, but it's actually fear of taking the case. It's a fear of being unsuccessful and failing. The patient is left in limbo, and the dentist often feels guilty for lacking the confidence to help, especially since it's our mission to provide health to that patient. A few years ago, those who mastered veneers, contact lenses, dental aesthetics, became a reference because there were few good dentists in the market providing aesthetics. Today, it's become a war, a market war, over price, over speed. Demand isn't as high as the number of professionals who know how to do it. But tell me, how many dentists in your region master the differential diagnosis of bruxism in a structured way? Do they know if the patient has apnea or not? Do they master the diagnosis and know why the patient has bruxism, why they snore, and why they have apnea, what type of apnea it is, and what the path to treatment is for that patient? How many know how to classify the intensity and type of bruxism and apnea? How many know how to correlate it with respiratory disorders and other medical fields associated with it, which are also important hooks for you to receive and refer patients? How many know how to treat and control it with a protocol, a scientifically validated path with clinical application? Almost no one. And that's exactly where your golden opportunity lies. This is the moment. Here in this journey, you'll learn real advanced dentistry. You'll learn to integrate bruxism, snoring, and apnea into your clinical reasoning without leaving your specialty. On the contrary, you'll enhance what you already do. You'll increase your average ticket right from the first consultation with differential exams without needing to attract new patients. This is very important. Even if you don't charge for consultations today or take insurance, in a few months, you'll have the confidence to diagnose, treat, and control bruxism, snoring, and apnea with authority. And when you master this area, you stop being just another dentist. You become a reference on the subject, regardless of whether you've been graduated for 5 years or have 40 years in the profession, because what defines a new era isn't the time since graduation. Today, I'm here to teach you something that took me years to build, something born from frustration, from an anguish of seeing my own work fail, even though I have a master's, a doctorate, and deep mastery of materials science with engineering involved. I've always been passionate about the scientific side. When I went to take the entrance exams, I was torn between medicine and dentistry. I put half of the options for each course, 2 federal and state universities in dentistry and 2 in medicine. In that historic year, something unusual happened. Practically all the universities went on strike except for UARJ. I'd already been accepted on the first list at UARJ for dentistry, which was at the time the best in Rio de Janeiro. The other exams hadn't even happened yet. And then I understood it was a sign. It was dentistry. In college, I was always involved academically. I was a teaching assistant for dental materials, prosthetics, and restorative dentistry. In my last term, I was already updating my skills in aesthetics before graduating. As soon as I graduated, I went straight into specialization. And I knew that I didn't want to abandon academic life. So right after specialization, I started a master's in materials science at the Military Institute of Engineering. And I dove deep into the strength of materials, adhesion, ceramics, biomaterials, grafting. After that, I went into periodontics to understand the patient as a whole, the foundation of health, and also grafting materials. And for my doctorate, I went to finish my PhD in restorative dentistry. I mastered the theory, the materials, and adhesion, but in the office, I still saw some cases failing. And that's when my biggest professional crisis began. I delivered perfect restorations, perfect adhesive protocols, perfect absolute isolation, the gold standard. And even so, the provisionals failed, restorations failed, and the patient lost tooth structure. And I often couldn't see this as a solvable problem. There was one case that marked me deeply. A long-term provisional milled in CAD/CAM with a laboratory strength of 100 megapascals. Pay attention. The manufacturer's promise was at least 1 year, a long-term provisional, my promise to the patient. And in 8 months, look, it was worn down. The patient was a dentist, a student of mine. Right then, I realized the problem isn't the material. The problem isn't the adhesive technique. The problem isn't the restoration. It was something I wasn't treating, wasn't diagnosing. I knew there was a link to bruxism, but what did I do? If there's bruxism and wear, use a splint. And that's what dentists learned over 20 years ago. Splints solve it. Splints protect. It's what we have. The patient has to use it. But I started to ask myself, why are they clenching? Why does it happen to one and not the other? What's happening with their sleep? What's the connection with the medications they take? How is this patient's anxiety? How is this patient's airway? Why do they snore? Why don't they snore? What is apnea? What's the relationship between bruxism and apnea? I didn't want to be just another dentist who only solved the patient's main dental complaint. I wanted to understand the patient as a whole and promote health. Because bruxism, snoring, and apnea aren't isolated problems, nor are they distant from dentistry. They're manifestations of something much bigger, dental and health manifestations. So I started applying the differential diagnosis protocol to all patients. Regardless of the complaint, regardless of why they came, I created structured forms, standardized head and neck palpation, classified bruxism evidence, started measuring, and realized something very important. Observing tooth wear is not a diagnosis of bruxism. It's observing the consequence. The end result, the problem. The solution lies before the problem. So the differential diagnosis required a method, but something was still missing. The patient didn't connect. I'd tell them what I was seeing in terms of wear and effraction, and often they'd say, no, I don't do anything. I sleep well. I don't have bruxism. I don't grind. I'm out. I lie down and I'm out. And even with the mouth screaming with signs, loss of vertical dimension of occlusion, canine fracture, exostosis, marked linea alba, incisal wear, all of that. And the patient didn't connect. They'd say they didn't. So then in 2019, after nearly 10 years of studying bruxism, I developed and published the diagnostic plate exam, a complementary differential exam capable of visually showing the patient if they clench, if they grind, which side, what intensity, if it's mild, moderate, or advanced, if there's specific overload on a single tooth, if there's a centric or eccentric clenching pattern. And when the patient saw the diagnostic plate exam, what they were doing at night, I no longer had to keep competing with them over who was right. I didn't need to convince them anymore. I didn't have to beg that patient to come for treatment. I didn't need to justify dental or restorative failures. The exam showed what they did during the night, and they connected with the problem they themselves were having, which is grinding at night or clenching at night. So that's where the DTC methodology was born: differential diagnosis, treatment, control, with protocol sequence, with replicability. After the pandemic, the number of patients with bruxism, snoring, apnea exploded. Out of every 10 patients, 7 or 8 often showed some degree, some evidence that they were clenching their teeth. And now I had then clinical safety, longevity in my treatments, predictability, authority, and connection with the patient. Patients started referring me. Dentists came from other states to treat with me, and I understood. This couldn't stay only in my clinic, in my office, just with me. I started teaching in person, then online. I started measuring the results of other dentists, and then I realized something much more powerful. In up to 8 weeks, the vast majority of dentists were already able to apply the method, regardless of their area of practice, of their specialty. General practitioner, implantologist, orthodontist, rehabilitator, all in 8 weeks were able to perform the methodology. And what changed in their lives then? More clinical safety, greater authority, greater recognition, increased revenue as a consequence of standing out in something that has no prominence. Most dentists don't know, even without charging for a consultation, even taking insurance, because bruxism, snoring, apnea are issues that today happen in all spheres, in all scales of patients, and it's the fastest growing area. Mastering this is mastering the new era of dentistry. And it's exactly this method that was born from my frustration, from my crisis, and restorative difficulties in the office of longevity, from my search for real answers for the patient that I'm going to teach you in this masterclass. And who is this masterclass for? This masterclass is for you who works at the chair every day, for you who doesn't charge for a consultation, who takes insurance, for those who charge for consultations too, for those who rent a room or earn a percentage, for those who have an office, for those who have a clinic, for those who work for others, for those who already have clinical experience, for those who have already taken courses, specializations, updates, and even so, feel insecure, and for those who have been graduated for more than 5, 10, 20, 30 years, 40 years too. It's for you who's feeling that dentistry is changing and doesn't want to become outdated, regardless of your age and how long you've been graduated. For you who treats patients. Patients are different, more anxious, more medicated, sleeping worse, but maybe you're still not prepared to connect with these patients and real clinical cases. Maybe you haven't realized yet that bruxism, snoring, and apnea might be behind many challenges you face today in the office. And this masterclass is exactly to open up this new perspective. It's not about you learning how to make a splint. It's about you discovering a clinical opportunity that can reposition you in the new era of dentistry or position you for the first time as a standout in your region. If you feel you can evolve, that you can see beyond the main complaint, that you can become a reference, then this masterclass is for you. Now, I'm going to teach you and prove 4 reasons among the main problems and opportunities of the new era of dentistry. The first reason 1, the fastest growing problem is already in your chair: bruxism, snoring, and apnea. This reason is very simple. They won't stop growing. Today, they are the fastest growing problem in dentistry. In Brazil, about 40% of the population shows some degree of bruxism. In children, the number often already reaches nearly 50% at different ages. This increased a lot after the pandemic. More anxiety, more medication, sleep disorders, racing thoughts, use of screens and devices. But that's not all. Now think with me. Brazil is the country with the highest number of dental surgeons in the entire world. Did you know that? But how many are references in bruxism, snoring, and apnea? Percentage? Negligible. Almost none. In other words, the demand already exists. The patient is already in your chair. But not even 5% of dentists are trained to take on these cases. And this is where I want to break a very important belief for you. You might be thinking bruxism has always existed. Yes, but never in this proportion, and never with this systemic impact, and never with this level of demand, and never with this treatment methodology and real response to the patient beyond the splint. It was believed that bruxism was just a splint and that's it. Today we know it's not. Whoever wants to master this area now isn't coming in late. They're entering at the exact moment of the turning point. You'll surf the wave at the right time. I know many dentists have long-time patients going through these difficulties and end up leaving patients without answers, without diagnosis, without treatment. And because of that, it's exactly because of that, that there's a great opportunity, because you don't need to fight, because you don't need to pack your schedule or do little dances on the internet. Nothing against those who do, or attract new patients at any cost for you to gain this prominence, because you already have the patients in the chair. Think about this moment right now. How many patients are suffering from bruxism, snoring, or apnea who are already your longtime patients? And maybe you don't even know. I'm going to teach you how to bring this patient back with this vision. Sometimes you already know they have it, but they don't. And you'll have the chance to discover and save this patient by offering a real treatment. And the second reason, Andrea, your specialty doesn't matter. The second reason, super simple and objective, because I want to be very objective in today's class, is it doesn't matter if you're a general practitioner or a specialist in any area of dentistry. Your patient's bruxism, snoring, apnea directly impact what you do every day. If you're an implantologist, occlusal overload increases the risk of screw fracture or implant loss or bone loss, or prosthetic loosening and early failure. Undiagnosed bruxism compromises your implant. If you're an endodontist, cracks, fissures, longitudinal fractures, and even periapical lesions can be associated with occlusal trauma from bruxism. You treat the canal, but the problem continues. It remains active. If you're an orthodontist, clenching with aligners, the patient has a headache after putting on the aligner, or has a quick relapse, overload on certain teeth due to problems related to bruxism, clenching, muscle pain. Without understanding your patient's bruxism and breathing pattern, the treatment loses stability. Orthodontic treatment will suffer. If you're a periodontist, occlusal overload worsens bone loss. Inflammation plus trauma accelerates periodontal destruction. And if you're a restorative or rehab specialist, you're seeing early wear on restorations, ceramic fractures, loss of vertical dimension, and persistent sensitivity. Then if you're a general practitioner, you're the gateway for all these cases. How many crowns are coming loose? Rework, how many times will you keep redoing it, facing clinical failures and being blamed for it? Now, I want to break a very important belief as well. Maybe you think this is for TMJ specialists. It's not. Bruxism is not TMJ. Snoring is not TMJ. And apnea is not TMJ. They're movement disorders. They're issues related to sleep processes. They have a real impact on dentistry. And what changes isn't your specialty. It's your perspective. When you master bruxism, snoring, and apnea, you'll protect your implants, your restorations, your patient's health, your orthodontic treatments, your rehabilitation cases. You'll gain predictability. And the experienced dentists, they don't want to do more. They don't want to see more patients. They want to make it last and make it perfect. You need to maintain or create once and for all your authority, your recognition, get out of the price war, and not depend on patient volume. You can't be left behind. It's time to make that shift. The third reason is that the old model market is saturated. Yes, technical dentistry has become a commodity. Dentistry has become selling a service. Veneers have become price comparisons, a commodity. Implants have become about payment plans. Whoever offers the cheapest screw with the most installments will win the patient's favor. Aligners have become a market battle of who does the best marketing. Today, in many cities, patients compare prices before comparing diagnosis and planning. This creates physical and emotional strain for the dentist. You're not there to sell a screw. This emotional, financial, and professional strain, it all leads to unhappiness in the profession. Now, let me ask you a very important question. How many dentists in your area master bruxism, snoring, and apnea with a structured differential diagnosis and know how to deliver, to verbalize to the patient the problem they have, how to treat it, and how to control it? How many have a clear method for diagnosis, treatment, and control? Almost none. They'll give a mouth guard, not really understand what to do, not know how to diagnose. They often do a basic college-level anamnesis. And this is where I need to break another belief. Maybe you're thinking, in my city, in my region, patients don't have the money to pay. It's very hard to sell and close. But almost no dentist is, in fact, positioned in the new era of clinical dentistry. Differentiation today isn't in the procedure, the implant, the veneer, or the restoration. It's in the clinical reasoning. It's in seeing what other dentists, other professionals are not yet seeing. When you master bruxism, snoring, and apnea, you stop competing on price. You start being sought out for confidence in your field, for being distinct, doing what not even 5% of dentists do, for authority, for vision, for competence, for seeing beyond the tooth. And the experienced dentist also doesn't want to be chosen as a commodity. Who's the cheapest? Who has the best payment plan? You want to be chosen as a reference. And being a reference doesn't come from a procedure. It comes from positioning. When you learn to treat bruxism, when you deliver a real bruxism treatment, which I'll explain to you, snoring and apnea bruxism are matters of bringing health to your patient. When you do this with clinical safety, you don't just add a new procedure to your routine. You change your positioning as a professional. If you're a general practitioner or already a specialist in some area, you already do routine appointments in your office. But no one has done a differential diagnosis structured for that patient, and that's where you come in. When you master the 360 diagnosis, you understand intensity, type of bruxism, primary, secondary, associated diseases. When you know how to correlate it with apnea, with medication, you're no longer competing just on the price of procedures. You're starting from a position of authority, and authority cannot be transferred. When you present the financial planning, when you present the value, your patient doesn't compare you with the competitor if you're differentiated. And why didn't the competitor deliver the same reasoning? Why didn't they make the same reading? Because they don't know. They didn't have a clinical vision on this subject. And that completely changes the game. I know you already have clinical safety in what you do: restoration, orthodontics, surgery, periodontics. But repeated experience without updating becomes routine and doing the same thing. Routine doesn't generate differentiation. When you add this new positioning, you accelerate something that might take years to happen, becoming a reference in something that doesn't exist. The market is in high demand for professionals who actually know how to diagnose, treat, and control bruxism, snoring, and apnea, and there are no professionals for this. So when you become a reference for something that's happening today, scientifically backed, you turn the key to the office. Sometimes you might have 20, 25, 30 years of experience, and you've been doing the same thing for decades. But the market changed, the patient shifted, science evolved. Today, looking at a patient with wear is not the same way you looked 10 years ago, 5 years ago. And those who learn to see what others haven't seen yet jump ahead. It's not about doing more of the same. It's about doing it differently with methodology. The fourth reason for you to become a reference in bruxism, snoring, and apnea is the most strategic reason of all. Dentistry has always valued complementary exams. You don't do endodontics without an X-ray. You don't do an implant without a CT scan. You don't do orthodontics without documentation. But when it comes to bruxism, snoring, and apnea, most dentists still work on guesswork. They observe wear, deliver a plate, and wait. The great opportunity lies in differentiated complementary exams, especially in the diagnostic plate exam, because it transforms the opinion, the guesswork that the patient is clenching or grinding into concrete proof. It shows if the patient is clenching that night, those nights. The type of movement, intensity, predominant side, whether it's centric, eccentric, mild, moderate, or advanced. You stop convincing, you stop having to bargain with the patient that they really clench or grind. You start showing them it's a visual exam. And this is where I break a very important belief. When you think, I don't know how to sell treatment, so I'm not going to get into this. You don't need to sell, you need to diagnose. When the patient sees what they do during the night, the decision stops being emotional and becomes rational. There is something even more powerful. The differential exam allows you to increase the average ticket right at the first appointment, even if you don't charge for it, even if you take insurance because it doesn't cover the exam, without getting new patients because insurance doesn't pay, but the patient understands they need it when you show them there's an exam that shows evidence of bruxism in the mouth. Structured diagnosis has value. It's not about selling a mouth guard, it's about selling clarity and promoting health. When you sell with clarity, you gain authority, and when you gain authority, revenue becomes a consequence. It's a consequence of who you are and the work you do. If the problem grows, it impacts all specialties, changes the market, and creates a financial opportunity. So the next step is to understand the current concept, because the wrong diagnosis will lead to the wrong treatment, and that will unfortunately cause problems for you. So wrong diagnosis, wrong treatment. According to the latest international consensus, actually, the most recent one, bruxism is no longer classified as a disease, as a disorder. It's defined as a masticatory muscle activity characterized by clenching or grinding of the teeth with repetitive mandibular movement, which can occur during sleep or while awake, daytime bruxism. There are two distinct contexts: sleep bruxism and awake bruxism. So we're going to talk about sleep bruxism, SB, and awake bruxism, AB, here in this consensus that I've brought to you. And the most important point of the current consensus is bruxism is a motor behavior. It can be a risk factor for other problems. It can be a protective factor, and I'll explain what that is. Or it can be neutral, not causing problems for the patient, which is very rare. Depending on the patient's systemic context, we have another view, because bruxism, it's not automatically a pathology, but it becomes a problem because of overload, pain, progressive wear, fracture, functional impairment, and an association with sleep disorders, such as apnea, for example, which completely changes the clinical reasoning. So according to the consensus, the current classification, the consensus organizes bruxism into 3 diagnostic levels. A possible bruxism based only on the patient's self-report, which I don't like. My partner says I grind, I wake up with a tired jaw, I think I grind. That's a possible bruxism. A probable bruxism would be a self-report, the same issues. My partner says I grind, I wake up with a tired jaw, plus evident clinical signs. Linea alba, exostosis, compatible wear, muscle hypertrophy, and recurrent fractures. That would be a probable bruxism. And defined bruxism, it's confirmed by instrumental examination. And this is where I want to get into. The polysomnography exam is the gold standard for defining sleep disorders. But I need a polysomnography that has an electromyography with sensors on the masseter and the chin. Not every lab does that. Now, the diagnostic plate exam, it can and should be done on all patients because this point is fundamental. Without the complementary exam, you work at the probable level. With the complementary exam, you raise the level of diagnostic safety. And then the current consensus, it defines the types of bruxism, differentiating then by the muscle pattern. There's tonic bruxism, which I really like to call centric, because the dentist understands that centric is clenching. It's a sustained contraction, little lateral movement, more muscle pain, and less visible wear. It's what the patient says. I wake up tired, I have muscle pain, but they don't show significant loss of tooth structure. Their biggest risk is longitudinal fracture, cracking, and overloaded implants. This is tonic bruxism or centric. Now, phasic. Phasic is eccentric movement, rhythmic contractions, repetitive lateral movements, grinding. It's the famous grinding, the classic. It's the patient who wears down canine tips, loses guidance, develops interference, progresses to abfraction, but has less muscle pain and more structural wear. And mixed, where they do both, they clench and they grind. A combination of tonic and phasic, centric and eccentric. Very common in clinical practice. The intensity isn't just visual, it considers the frequency of episodes, the duration of contractions, the force applied, and the structural impact. And the practical clinical classification is mild initial wear without fracture or relevant pain, moderate loss of structure, interference, occasional fractures, eventual headache, and severe loss of vertical dimension of occlusion, recurrent fractures, compromised implants, chronic muscle pain, systemic impact. Intensity changes everything. Intensity changes the approach, changes the restorative prognosis, changes the scale of the case, then primary or secondary. This is a very neglected point in dentistry today. Primary bruxism is that which has no identifiable systemic cause. It may have a genetic or neurophysiological basis, but the cause cannot be diagnosed. It's primary, nothing was found. No medication was found, no apnea was found, no real reason for this bruxism was found. Secondary bruxism is associated with sleep disorders, obstructive sleep apnea, the use of antidepressants, anxiety, gastroesophageal reflux, and neurological changes. And here enters the new era of dentists who understand this patient. Bruxism and apnea go hand in hand. And here's the key insight. There is bruxism secondary to apnea. After an oxygen desaturation event during sleep apnea, the brain detects this drop in oxygen and a microarousal occurs. There's sympathetic activation, adrenaline, the jaw moves, and the patient grinds. In other words, at this moment, they call bruxism protective. Grinding as a consequence of the apnea microarousal, which makes the patient start breathing again. This is important. You completely change your approach because you don't just treat the tooth. You need to evaluate the airway to see why this patient is having apnea or not. Flat splints, Michigan splints. The gold standard splints in the literature for bruxism can increase the risk of airway collapse in some patients, as I've brought this study here for you to see. And that's why differential diagnosis is essential, because if bruxism is secondary to apnea, the device is different. It's not a bruxism splint. Bruxism today is a motor behavior, multifactorial. It can be primary or secondary. It can be associated with apnea, be tonic, phasic, or mixed. It can have variable intensity and be daytime or nighttime bruxism. So without classifying type, intensity, and origin, you don't make a differential diagnosis. You just observe where, a consequence. And this is where the DTC methodology actually begins. The method I developed was created so that you become a reference in bruxism in your region, increasing your revenue with integrity, even if today you don't charge for consultations or work with health insurance, through 3 pillars: differential diagnosis, treatment, and control of bruxism. These 3 pillars are divided into stages. And that's exactly why the method is replicable for any dentist from any area, any specialty, or general practitioner. Within the differential diagnosis, we have 4 stages. And the first is the basis of the whole process, the DP4 chart, the 360-degree chart. 360 degrees, because you need to have a chart that goes beyond the basic, beyond the obvious. It goes beyond those college questions like, do you have allergies? Is there any medication you can't take? Have you had prolapse or rheumatic fever? And that's it. You need a chart with health and behavioral information that is truly relevant. It's very likely that today you use something that is outdated or focused only on teeth, that basic anamnesis that we learn in college, with generic questions about family diseases, allergies, some history, and that doesn't keep up with the patient today. The patient has changed and you need to change too. You can no longer limit yourself to looking only at the tooth, at the where, at the problem. You need to have a 360 approach because the mouth is part of a living organism, and many factors directly influence oral health and the treatments you already perform. The 360 chart is the union of forms validated in the literature, applied and tested in my clinical reality, and in the clinical reality of thousands of dentists in Brazil and over 25 countries. This chart extracts valuable information. And here is a very important point. The patient fills it out, receives a score for their possibility of having mild, moderate, or advanced bruxism, their stress level, sleep, and respiratory difficulties, and a score that already comes with a final answer indicating the chance of mild, moderate, or advanced bruxism. In other words, you already have proof of possibility. Now, you already start with evidence, and the closing of the differential diagnosis happens with the accumulation of evidence gathered in the stages of the DTC methodology. But it all starts with the 360 chart. For all patients, all of them, regardless of your specialty, you need to apply the 360 chart because you will see much more than you see today. And maybe you're thinking, but Andrea, if the patient only wants to do that one tooth, will they fill it out? Why would I do something different? I understand you. We learn to listen, welcome, and respect others. And sometimes it seems that going a little beyond what they're asking for is forcing something they don't want. It feels like you're doing something wrong. But this posture of offering what they really need, which is to diagnose in a differentiated way, to investigate, to go deeper, will be born from the real care you want to have for your patient. It's born from a concern. You want the best. Talking to the patient about the issues they're reporting. And then we move to the second stage, which is an extra and intraoral evaluation. Notice that everything I've mentioned so far, you're already doing. You already talk to the patient. You already do an anamnesis. You already look at the patient's mouth. However, I'm going to do this in a detailed and structured way, the same for every patient, adding a 360-degree view you don't have yet, but that I'm showing you. In this extra and intraoral evaluation, we'll do something very few dentists do today. In the extraoral evaluation, we start with a head and neck palpation, assessing the muscles involved in chewing and jaw elevation. The goal is to identify tension, nodules, or pain. And at this point, you can already tell if that headache patient who recorded a headache in the 360 record might have a tension headache by palpating the temporal, masseter, and cervical muscles. This palpation sets you apart in a way your patients aren't used to. Every time I palpate a patient, they say, "No one has ever done this to me before." And that is fundamental. If you find pain upon palpation, it means there's a tension point there, a trigger point. Often this point is an area that is, in fact, inflamed. It can be latent or active if they report spontaneous pain, and this already guides you on the type of movement the patient is making. If they have daytime clenching, for example, there's a high chance of pain upon palpation. A more predominant eccentric movement, bruxism, they grind, wear down more teeth, and have less muscle pain. They dissipate that energy through tooth degradation. Remember, your patient might do eccentric grinding at night, wearing down teeth, and centric clenching during the day. This will cause tooth wear, but they'll have muscle pain as well. So you're already heading towards the idea that this muscle pain could be from daytime clenching. And here, my goal isn't to lengthen your consultation. It's for you to be assertive, to show you're different. I'm talking about a few minutes at no cost at all, just to set you apart. Maybe you're thinking, wow, Andrea, but this consultation will take too long. It's a waste of time to keep palpating the head and neck and filling out forms. I understand you. As a dentist, the routine is super busy. One comes in, another leaves, one in, one out. Providing good service already demands a lot. Adding another step seems impossible. But let me tell you something important. It's precisely because it seems like a waste of time that it'll save you time later on. Why? Because when you do a differential diagnosis, you avoid the rework of a fracture. If this patient has many muscle nodules, if this patient is already reporting there in the 360 medical record, he's reporting it. It's evident. He has hypertrophied muscle. He has fatigued muscle. You'll invariably have a waste of time if restorations happen to fracture. You'll avoid errors in conduct and prevent the patient from getting upset and not coming back. Patients don't like having a fracture in a newly made restoration. They notice when something wasn't properly resolved. They notice sensitivity. Often this complaint of sensitivity is related to clenching. And this palpation causing pain will make them see that something is wrong. You see in the first consultation what other professionals only discover after 3 or 4 sessions, sometimes months or never. And when does this happen, Andrea? Do you know what happens? When the patient feels the difference of this first consultation, they feel you've really seen what they have and are going deep. And they start to trust more, adhere more, and connect more. This extraoral palpation doesn't even take 5 minutes and costs nothing. You don't have to buy any equipment. You stand out in the market without spending anything on new equipment, improving your analysis and positioning yourself as an authority. And in the intraoral analysis, Andrea, before looking at the teeth, I want you to look at the airways. As you're seeing here, from the 360 medical record of the palpation, you go to the intraoral analysis, extra and intraoral. Don't go straight to the tooth. You'll evaluate if this patient has a partial airway obstruction or not. How, Andrea? A simple and free visual exam called the Malampati classification. What's that, Andrea? I've never heard of it. This is very common for ENTs. It's very common for anesthesiologists, for those who intubate. Pay attention. When you do a Malampati classification, if you start doing this today, you'll already see the difference. We visually evaluate the airway space. When the patient opens their mouth and says, you observe the opening of type 1, 2, 3, and 4. In practice, types 3 and 4 are risk classifications, risk of apnea and snoring. Why? Because there's less airway opening with a higher chance of obstruction during sleep. But it doesn't mean he has apnea just because he's a 3 or 4. And it also doesn't mean that 1 and 2 don't have apnea. I can only truly confirm apnea in the differential complementary exam that I'll present to you shortly. But notice, you're collecting information that probably no other professional has analyzed. You're going beyond the obvious. You're already standing out. You're looking at something no one saw, caring for your patient's health like no one else. And today, your patient, the human being, wants to be cared for. No one wants to go to a clinic just to be another number. They want to feel special. They want to feel seen. They want you to observe. It's no use putting a little tea in the reception if you don't have content. Without content, authority isn't sustained. It's no use doing marketing, making tea, or having nice upholstery without content. Over time, they'll notice and your authority won't be sustainable. So once you've quickly assessed Malampati, you'll also evaluate intraoral evidence of bruxism. But before you evaluate intraoral evidence of bruxism, I want to remind you that assessments in your specialty will stay the same. So if you're an orthodontist, you'll observe canine guidance. So if you're an orthodontist, you'll observe crowding, guidance, angle classification, need for anteroposterior correction as usual. Just introduce some more evidence that I'm going to explain to you. If you're a periodontist, you'll likewise continue doing your probing mobility assessment, everything the same. If you're a general practitioner, you'll observe everything. Periodontium, fractures, cavities as usual. If you're in restorative dentistry and evaluate aesthetic restorations, you'll keep doing that too. And if you're a rehabilitator with patients with heavy wear, all the more reason to add everything I'll teach you now. Everything continues as you already do, but in addition, you'll look for evidence of bruxism. How? What evidence is that? A scalloped tongue is evidence of clenching. The edge of the tongue, forming those scalloped clouds, as you see here in this image, a scalloped tongue. A very evident linea alba is also linked to clenching. Wear, worn teeth, wear facets, fractures, fissures, exostosis. All of this added to failing restorations and abfractions. Besides that, what else will you have? Masseter hypertrophy. So this is the time for you to collect the data. This is the time to combine bruxism data with your specialty. I don't want you to leave your specialty. I want you to add bruxism as the icing on the cake, as a differentiator in your field, because patients do it and no one talks about it. And you can be that person. Now, the third stage of differential diagnosis, the differential complementary exams, this will surely increase your average ticket and take you to another level. In our clinical routine, we're used to requesting x-rays, either full periapical, panoramic, a CT scan, or cephalometric if you're an ortho, depending on the case. Why are we used to asking for x-rays? Because you want to restore, operate, do a root canal, perio-rehabilitate, in short, see what's actually inside. This is routine. We can't see bone or mineralized tissue with the naked eye. We need x-rays, right? Yes, Andrea, that's normal. But the patient has changed. And it's not just an x-ray that we need. The patient's history has changed. This patient's history now comes with evidence of bruxism and possible apnea because you gathered information from the chart and you need to keep up with this change. There are 2 differential complementary exams you don't use today that will change your 360-degree view. This will increase your average ticket, give you authority, and bring new life to the clinic, both financially and in understanding the patient 360 degrees. And I want you to understand something. Nocturnal bruxism is a sleep-related problem. It's the tip of the iceberg, because if you don't sleep, you have other problems. Sleep bruxism starts in light sleep. It usually happens in light sleep, in NREM 2. I won't talk about that now, but I want you to understand that you don't sleep with your patient. So you don't monitor what he does during the night. You can't control this just by looking in the patient's mouth or believing their self-report. So seeing the patient as a whole is understanding if they're sleeping well or not, moving or not, having apnea or not. You don't sleep with them, you don't know. So offer them the first exam, the diagnostic plate exam. For whom, Andrea? For every patient. The first differential complementary exam is the diagnostic plate exam. I call it DPE. Maybe you've never heard of it, and I understand you. I published it in 2019. Since then, I've applied it to all patients. And thousands of students already apply it in their daily clinical practice in over 25 countries. You need to understand about this exam. First, it's an exam. It's not a night guard. It's not bruxism treatment. It's an exam. It's an exam to see what your patient does at night and know if it's mild, moderate, or advanced, centric or eccentric, tonic or phasic. And what are they doing? Second, there's a huge percentage of patients you only discover have bruxism with this exam because they have no tooth wear. Often, this patient is grinding, starting eccentric bruxism, no wear yet, or doing centric, but never complained, never reported anything. And then on that specific tooth, at night, you discover, as in this image, that they're making excessive contact on that tooth. So it's a powerful tool. It's an exam full of information. It'll show you the type of movement your patient makes at night, the intensity of bruxism, if they sleep more on the right side, more on the left, or if they sleep in a supine position. And there's a reading methodology for you to interpret this exam, but it's totally feasible and reproducible for any dentist, regardless of how long they've been graduated, to do it. And here comes something very important. When the patient can see what they do at night, in fact, they see it in the exam, understand it, and buy into what they believe, and they believe in what they're seeing. That's why the diagnostic plate exam cannot be ignored in your office. It's a fundamental exam. It makes the patient convert, and it should be applied in daily clinical practice because you don't sleep with the patient, you don't know what they do at night. This is a point that changes everything. And the commercial point with integrity is that besides generating clinical evidence, an exam that tells intensity, position, type of touch, the exam that can indeed be applied to any patient from 5 years of age, you can already increase your revenue in the first consultation with integrity with something that won't bring any harm to the patient. On the contrary, it's a painless exam they do at home while sleeping. Even if today you don't charge for a consultation, even if the patient comes through insurance. Why? Because this exam isn't paid for by health insurance, so you can offer it. It's a necessary exam, an exam the patient can afford, an exam where you'll convert the patient, connect with this patient, so you charge separately and the patient pays because it's an exam that makes sense to them. Maybe you're thinking right now, Andrea, why do I need to do this exam if I already see there's no canine tip, if I already see wear, if they already arrived with a fractured tooth? I need to. I'm seeing what they're doing. They lost the tooth. I'll give you 4 reasons for you to apply the DPE to every patient, even the one who comes with a fractured tooth. When this patient already comes with the certainty that they have bruxism, I need to understand if the patient is grinding and hasn't lost tooth structure, if they're moving and haven't lost tooth structure. In other words, for a patient with centric or daytime bruxism who might not have lost tooth structure, I'll apply it. It can explain this fissure, the muscle pain. And before this fracture happened, if you'd done the exam as a clinic protocol, you'd realize the tooth was at risk and maybe wouldn't lose it because you'd treat it. Second reason, you don't know the intensity of this movement. You don't know the pressure, the size of the wear, the level of bruxism, nor which side they predominantly sleep on, nor the severity, mild, moderate, or advanced. You can see a fracture, a fissure, an absence of guidance. You can see a hypertrophied masseter, but these are just evidence. It doesn't confirm a diagnosis that at that moment, they have moderate bruxism with predominant eccentric movement, for example, only by doing the exam. You need the exam. Furthermore, the exam can help you differentiate if they're moving a lot at night or if the bruxism is more while awake. If the patient complains of muscle pain, but the diagnostic plate exam doesn't show much evidence of nocturnal bruxism, this clenching movement is more during the day. This changes the treatment. So this is a reason that validates the need to request the diagnostic plate exam. The third reason is to know if the bruxism is active at that moment, as I said. If the patient already arrives with wear, this wear could be old, it could be from the past. And if this bruxism isn't active at that moment and was from the past, maybe they don't need to use a plate right now, even if they have wear. You might end up selling a plate just because you saw a worn tooth. That's not the way. Actually, if you do the diagnostic plate exam when the patient already has wear, and if at that moment the bruxism isn't active, you'll combine it with the 360 chart responses and change the treatment plan. See how clinical conduct changes according to the response of the evidence I'm seeing in the patient's mouth with the chart, with the differentiated complementary exam. And the fourth reason is that your clinical authority and connection with the patient increases. So when you show the patient what they do during sleep, it becomes disruptive. You prove it, you don't guess, you show it. This builds trust, connection, adherence. The patient feels truly cared for, doing something simple, objective, that won't hurt, won't be painful, and will be something unique to your clinic. Doing a simple calculation with integrity with you, a lot of integrity. Out of every 10 patients in the office, 8 show some type of evidence of bruxism. You put the exam into your routine. For example, out of every 10 patients, 8 show masseter hypertrophy, abfraction, loss of canine tip, and you're an ortho or an endo and you're going to do that endo. But you want to know if the patient has bruxism or not, especially on that tooth you're going to treat. You want to know if there's an occlusal overload there during the night or not. Totally legitimate. Many of my students charge from 400 to 2,000 reais, depending on the region, for the diagnosis. So the average cost of the exam, the differential diagnosis with the exams, the average cost of the exam for the dentist is around 150 reais, including everything. lamination, ink, everything, considering all materials and production time as well. If you charge the minimum amount of 400, I'll put it at the minimum. You have an approximate margin of 250 reais. So let's round down. 8 patients at 250 reais, that's 2,000 reais per week. 8 patients, 8 patients. How many do you see per week? I'm only putting 8. In 1 month, we're talking about 8,000 reais on the lowest base, lowest. In 1 year, we're talking about 96,000 reais. It's a value that you often haven't realized has no risk of going wrong. It's an exam. It'll always work. It's painless. And it's not currently part of your revenue. That's an exam. Besides that, there's the Bruxism treatment. Once linked to the exam, then you move to treatment, which ranges from about 2,700 to 6,000 reais, depending on complexity, the path, and your region. This increases the average ticket, making you a reference in something few do without leaving your specialty. And Andrea, you mentioned 2 differential exams. What's the other? The other one is a polysomnography. What do you mean, Andrea? Am I going to order a sleep study for everyone? Will the guy have to sleep away from home? No, he won't sleep away from home. You won't order a type 1 sleep study for all your patients because that's incompatible with clinical reality. We only get that with literature, only by doing scientific research for a number of people willing to participate in that study. That's not it. We'll order a type 1 sleep study when indicated, but now I want you to pay attention to something. There's a sleep study where we can have the machine in our office, and within the differential exams, I need to rule out possible apnea. Why? Because if my patient has apnea, I shouldn't use the flat plate as part of the Bruxism treatment, the gold standard plate. So that's the problem. I need to know if the patient is apneic or not. And that's where the second differential exam comes in, the sleep study, which can be type 3 or 4. This is an exam that we as dentists are fully authorized to offer by the board. It's also an ethical source of income because it's necessary, non-invasive, can't go wrong. The patient needs it and does it while sleeping. It guides the Bruxism treatment, gives you the confidence to use the right device, and confirms or rules out obstructive events during the night. Period. Necessary. It increases the ticket and establishes you as a reference. Often we are the first professionals to raise this suspicion of apnea and manage to direct this diagnosis to the patient. Do you realize how this is raising the dentist's level? This positions you as a true authority, improving your patient's health. And there's a very important detail. It's an exam that generates this revenue without you being at the dental chair. The patient does it while sleeping at home, literally. You earn money while sleeping, literally. The report comes ready from the system, from the equipment's algorithm, with their signature and a simplified reading. This gives you clinical security without tying you down to another procedure. It's literally a model where you don't depend on the wear and tear of your body, spine, eyes, or hands to generate revenue. With the complementary exams done and this stage understood, comes the 4th stage of differential diagnosis, which is the 360 record plus extra and intraoral evaluation, plus the diagnostic plate exam, plus the sleep study, plus all these findings and results. We will then finalize the case and provide support for this patient. This stage is indispensable, okay? Because it's no use collecting evidence if you don't know how to organize this information and turn it into a clear, safe, and personalized plan. But understand something. You are no longer in the field of guesswork. Now you are in the field of evidence. This completely changes how you view the patient in order to lead them into treatment. So understand a very important point. You need to finalize the differential diagnosis so you can apply it and then perform the correct treatment. So it's like when a patient arrives today in daily clinical practice, you order an x-ray to finalize the treatment. You'll do the same thing. You'll finalize the differential diagnosis to provide assertive treatment. Given then whether the patient has bruxism or not, we move on to treatment. This will go hand in hand with your specialty. I don't want the patient to have bruxism or apnea, but I want to diagnose this patient. If they do, we enter the second pillar, which is the treatment pillar. And now we find in this pillar a very important point, a real structuring of a treatment for bruxism and apnea. So what happens in the first stage of bruxism treatment? Pre-sleep treatment. Pre-sleep treatment includes sleep hygiene, prescription, guidance on eating habits, preparation for this patient to sleep, because we prepare to sleep from the moment we wake up. And there's something personalized for each patient. It's not the same for everyone. Maybe you've never seen a hypnogram, but what you're seeing now is a hypnogram, and it's called a sleep cycle. We have 4 main stages of sleep. Each cycle lasts on average 1.5 to 2 hours. In an 8-hour night sleep on average, we have 4 complete cycles. And that's why we say exactly that adults need to sleep between 7 and 8 hours a night so that they have up to 4 complete cycles. Do you know where bruxism occurs most frequently? In stage N2, the light sleep stage. If your patient has a lot of bruxism, has worn teeth, you need to investigate because most likely they're not reaching the amount of deep sleep hours they need. And that's why I say that bruxism is the tip of the iceberg, because it could be starting a low quality of sleep and life, because bruxism as a repetitive movement, ordered or not, that happens during sleep, which shouldn't happen, is showing that in fact this patient doesn't have healthy sleep. It's classified as a problem actually related to sleep, according to the American Academy of Sleep Medicine. It's not just dental wear. We need to understand that sleep hygiene isn't a basic formula for everyone. We need to personalize it. And as important as understanding the sleep cycle is knowing how to teach the patient how they'll prepare for sleep, what they'll do before, which stimulants they'll stop consuming, what they'll do as an eating routine, or the hours preceding sleep. This is all a personalized prescription, spoken, written, repeated, signed, just like brushing. We assume everyone knows how to brush their teeth, but when we go, we assume everyone knows how to brush their teeth. But when we do dental brushing techniques, we see that people they don't know brushing techniques, and sleeping well also requires technique. The patient thinks they know how to brush. When you teach them, they realize they don't know. Sleep is the same. Eating habits are the same. They think they sleep well. They think they do everything right. And then when you learn and teach, things change. But wait, I'm not calling you to become a nutritionist to prescribe diets. I'm not calling you to be the patient's general doctor. It's not that. But you need to understand the impact of food on bruxism, especially in the last hours of the day. The time they sleep, the time they eat, what they eat, much of the serotonin, basically all the serotonin in our body is produced in the gut by the intestinal microbiota. Changes in this microbiota can directly interfere with sleep quality and microawakenings. Excess of processed foods, dysbiosis, food intolerances, all of this can increase systemic inflammation. Inflammation that worsens sleep quality, that worsens bruxism. And besides that, there's still caffeine. Caffeine blocks adenosine receptors. What exactly is adenosine, Andrea? Adenosine is responsible for that feeling of sleep pressure, of tiredness. I need to sleep. When a patient consumes too much caffeine, it disrupts their natural sleep cycle. This can lead to an increase in bruxism episodes. And I know what you might be thinking. Man, I have so much dentistry to study. Where will I find the time to also understand sleep and nutrition? You don't need to become a top expert in sleep and nutrition, but you must understand their impact on your clinical practice. Things will fail, teeth will fracture, restorations will break, implants will be lost, and then you'll just be redoing work that was already done, or you'll lose the patient. Because the more bruxism there is, the more fractures occur. The more fractures, the more rework is needed. The more rework, the more it wears on your relationship with the patient too. So if you want your work to last and you want to practice great dentistry, then you need to understand this. What exactly is weakening the bond with the patient? Broken restorations, your veneers, your rehabilitations. A 360-degree view is just that. Now comes the second stage, custom splints. Now we're entering a stage where you might feel a certain comfort zone regarding splints. But I need to highlight something very important here. A splint doesn't treat bruxism, a splint protects. And there's a maxim in the literature that there's no evidence. I've brought it here for you. Look, there isn't enough evidence to claim that an occlusal splint treats bruxism or that it's the best technique for treating bruxism. It can help with dental protection, but it doesn't solve the underlying cause. So why is it part of the treatment, Andrea? Because we need to protect the tooth structure while we're treating the cause. There isn't just one type of splint. There are several different kinds. There's type 1, a daytime splint, which is a lower splint, light, comfortable, and allows for speech. I like to call it a cognitive splint. It helps the patient become aware of daytime clenching. And it can also serve as a vertical dimension test for patients who have lost their occlusal vertical dimension. The flat plane splint is the traditional one. It can be milled or fabricated right in the office. But pay attention, the Michigan splint, a flat plane splint, can be contraindicated for patients with obstructive sleep apnea. Yes, a flat plane splint is contraindicated for patients with obstructive sleep apnea because it can shift the jaw further back and worsen obstructive events. And that's why a differential diagnosis is vital, because you might be using the wrong splint, giving the wrong splint to a patient who has apnea without even knowing it. How many patients have you given splints to up until now? You have to call them back for a differential diagnosis and explain that science has evolved now. It has evolved. The protrusive splint, which is the third type, is indicated for patients with apnea. It advances the mandible, improves the airway, and can be temporary or permanent, like an intraoral appliance. Now, this must always be accompanied by gradual adaptation and gradual advancement. And here's where a strategic point comes in. Today, thousands of splints are sold online, including prefabricated ones without a diagnosis, like snoring mouth guards. If you don't have a structured methodology for each visit, the patient will compare you to those online splints. You become just a splint salesman, but without a visit-by-visit protocol, without a real methodology. In the DTC method, you are not a splint salesman. A beginning, a middle, and an end. Bruxism treatment lasts from 45 to 90 days. From 45 to 90. And stage 3 is the stage that will be the game changer. Almost no dentist does this. Supplementation, we're entering a stage that's often unknown at this point, which is supplementing the patient. First, I want to clarify something here. Supplementation is different from controlled medication. Many patients already arrive medicated with anxiolytics or antidepressants. And these medications can even increase bruxism episodes because if you have, for example, a serotonin reuptake inhibitor, an antidepressant, you'll alter the amount of circulating serotonin. This can also alter the amount of dopamine, which will interfere with motor coordination, increasing involuntary movements, and consequently, you'll have more bruxism. So if you're doing a rehabilitation and don't know if your patient uses a certain anxiolytic drug, this can increase the risk of fracture without you knowing. So you need to see it. It's not for you to become a psychiatrist, but you need to understand the clinical impact, the impact on restoration, on implants, on ortho, And here's an important point, because the dentist can prescribe supplementation related to their treatment as long as it directly impacts their clinical practice. So if in the differential diagnosis, it was found that there's bruxism/apnea, you can prescribe supplementation. If bruxism impacts your restorations, your surgeries, your rehabilitation, if bruxism is something within dentistry, you can act. And supplementation will vary according to the intensity of the bruxism, the type of movement, and the test results. And that's why the differential diagnosis is so important. I've brought you an article I published on supplementation in sleep dentistry related to bruxism, validating the technique, validating the supplement, validating this for the lives of clinicians. Now, step 4, the final stage of treatment, is occlusal adjustment. And I want to bring clarity to this stage. First, occlusal adjustment does not treat bruxism. Look at this study here showing it. Occlusal adjustment does not treat bruxism. Here at the university, the number of patients with malocclusion, bruxism, and TMD was researched, and it was considered a significant sample size. What was found? That those with malocclusion had no correlation with bruxism. But those who had bruxism, especially daytime bruxism, had a correlation with muscle pain. This makes perfect sense clinically, but when we bring in a literature review, it's to explain. Don't think that occlusal adjustment treats bruxism as was thought in the past. But occlusal adjustment, which can be additive, increasing canine guidance, for example, re-establishing canine guidance, orthodontic tooth movement, or subtractive, in very few situations, this occlusal adjustment is part of the treatment to avoid dental problems. For example, if the patient lost canine guidance, this creates interference. It can increase abfraction, increase fracture, increase recession, and root exposure. So occlusal adjustment can be a canine guidance reconstruction. It can be orthodontics. It can be an entire rehabilitation if the patient lost vertical dimension of occlusion. And this will indeed be related to the posture of the mandible. But you don't have to do everything. You don't have to be a rehabilitator. You need to lead the case, see what needs to be done. You're the leader of the bruxism and apnea treatment, but not necessarily the one who will do everything for the patient. This is an important point. Reestablish what was lost. Correct what is wrong to maintain your patient's oral health. Taking your patient from point A to point B, we then enter the control pillar, the final pillar of the DTC methodology. Every 4 months, we'll do follow-up appointments, re-evaluation, reinforcement, prevention, supplement correction, changes, splint adjustment, and splint removal. We'll make adjustments to the protrusive splints when there's apnea. We'll perform muscle management whenever it's necessary. So control keeps the patient in the office, preventing damage and fractures, ensuring they return, and opening doors for other dental treatments too. And that's often the moment when they say, oh, I want whitening. Oh, a cleaning. Oh, some cosmetic work, maybe a rehabilitation or orthodontics they didn't agree to at the start. But it all starts with that connection. And when you succeed in treating bruxism, that patient connects and won't leave you. If they see you're an authority who did the treatment, they're going to trust you. They'll trust you and they'll come back. So to wrap up, if your bruxism treatment today is just handing over a splint and adjusting it every 6 months, I have to tell you, you're outdated. And I say this with all the kindness in the world because I was also trained that way. Hand over a splint, protect, adjust, and goodbye. But today we have a method I've just shown you with scientific evidence, strategy, and clinical results. You can escape the price wars and the exhausting routine on the stool, straining your back, eyes, and arms more and more. You can move past this by growing your revenue with integrity, protecting your restorations and your work, becoming an authority, charging more, and best of all, without needing new patients. The patient is already in your chair. They just need you to see what no one else has seen. Dentist, look at me. After everything you've seen here, one thing is clear. Bruxism isn't a tooth problem. It's a sign, an alert, a message. And this might be the biggest shift in modern dentistry. We can't just treat the tip of the iceberg anymore, just the restoration or just giving out a splint. We can't just look at the surface anymore. We can't be trained to just fix a dental structure while ignoring the person, the patient, and their overall health. Because the mouth isn't isolated from the body. It's part of a living organism. Sleep, breathing, muscles, behavior, emotion, habits, medication, routine, supplements, life. When you start looking at it this way, you enter a new era. It's the era where you see the patient as a whole, 360 degrees. And it's the era where you stop just performing procedures and start managing health. The era where you're no longer remembered as the dentist who does, but respected as the dentist who sees. And I must tell you with total integrity, this isn't about selling splints or pushing things on patients. It's about clinical responsibility and respect for your patient. Because if you don't look at them this way, often no one else will do it. And there are many patients in your chair who are underdiagnosed with sleep apnea without knowing it. The patient doesn't have your training. They don't see what you see. They come in asking for a tooth. They come in complaining about pain, but they don't know what's behind it. There's a whole story behind it. And it's here at this moment that the movement begins. The movement of the dentist who goes beyond just teeth, the dentist who does what no one else does today. They see the patient as a whole, connect the signs, use the evidence, and deliver a plan with a beginning, middle, and end. No improvisation, no guesswork, no trial and error. That's why the DTC method exists. Differential diagnosis, treatment, and control. And now let me be very honest with you. What I've shown you so far was a vision, an opening of clinical awareness, but the complete DTC method can't fit into a single free class. And it's not because I don't want to give it to you, it's because there is depth and responsibility in what I'm teaching you. The criteria, the protocol, the clinical decisions, the supplements, the implementation, the pathways, the routine. Because it's not just about knowing it exists, it's about applying it. And it's exactly here that many dentists get stuck. They even understand it, they even think it's cool, but they can't turn it into a routine in their practice. And then the same old cycle repeats itself. A packed schedule, many hours in the chair, rework, frustration, restorations breaking, patients disappearing. It's that feeling that you work, but you're not valued as you should be. So stay with me until the end of this video. You won't regret it. I'm going to invite you to join a movement of dentists who have chosen to practice modern dentistry with a 360-degree perspective. Dentistry that goes beyond just treating the tooth as a result of delivering what the patient truly needs. And that's why today I'm opening exclusive spots for you to become a standard member of SIBX, the International Society of Bruxism, which currently operates in more than 25 countries with 2,000 members. What does it mean to become a standard member of SIBX? It means that you join an ecosystem of scientific updates and clinical applicability with a method, direction, and a ready-made path. And let me reassure you, you won't join and just receive a bunch of things and end up lost. No. You will join, start with a main track, a foundational track, an implementation path, and the track that supports all of this is the complete Bruxism from zero to advanced training based on the DTC method. This is where you learn the step-by-step process to conduct a 360-degree consultation, apply the 360-degree medical record, perform extra and intraoral evaluations, make an evidence-based differential diagnosis, carry out the diagnostic splint exam, and structure treatment and control with a clear beginning, middle, and end. And most importantly, you don't need to watch the entire training to get started. You start applying it in the very first week with the patient who's already in your chair. And what about the other trainings, Andrea? The other trainings are no longer extra work for you. They are complementary learning paths. They exist to give you confidence as your cases require. In other words, you don't have to study everything all at once. You start with the basics and unlock the rest as you progress and as your patient's needs demand. The complementary learning paths include, for example, the mandibular advancement device for snoring and sleep apnea, the intraoral advancement appliance, crisis management for muscle issues, musculature, how to treat a patient experiencing a pain crisis, interpreting imaging exams from a functional perspective, even if you're not an orthodontist, such as how a cephalometric analysis can impact the routine management of sleep apnea, for example, and pediatric bruxism, which is increasing dramatically. Even if you don't treat children, your patient's children might be showing some form of bruxism. So everything happens in its own time, everything with a purpose, so that you can truly become a 360-degree dentist. And what do you gain by joining this movement? You gain something that's currently missing in the market: direction. You will no longer have to rely on trial and error to know if it's right to apply something to your patient, or on guesswork, or on yet another random course, or on an isolated technique for something. You will have a clinical GPS, a way of looking at the patient and truly seeing them, knowing I know where to start, I know what I'm going to investigate, I know how to confirm this evidence, and I know how to treat beyond just the mouth guard. I know how to control and maintain this result. When the patient feels this, they trust you. And when they trust you, they commit, they stick with the treatment, they refer others, and that's how you become a reference in your area. Now comes the opportunity. So if you really want to enter this new era of dentistry, if you want to be part of the movement of dentists who go beyond just teeth, and if you want to start seeing the patient as a whole again and safely apply the DTC method in practice, I will be opening limited spots for you to become a standard member of SIBX. And as soon as you join, you will have immediate access to the main track, Advanced Bruxism from Scratch, the implementation roadmap so you can start applying it in the very first week, the complementary tracks to advance at your own pace, and the entire support and update ecosystem of the society. Pay close attention now, because what I'm about to show you is not just a training course. It's a complete structure for you to move away from fragmented dentistry and truly step into this 360-degree dentistry. By becoming a standard member of SIBX, you enter a structured ecosystem built on 3 pillars: clinical foundation with the DTC methodology, both clinical and scientific, technical and functional expansion, and authority with continuous updates. I'll explain this in a simpler way. Pillar 1 is the clinical and scientific foundation. Pillar 1 is the clinical foundation. The main training is Bruxism from zero advanced. This is the central module of your SIBX journey. It's not a random class. It's not fragmented content. It's a structured training divided into progressive modules, organized so you can move from the concept to real clinical application. You don't learn about Bruxism in a disjointed way. You learn how to make a differential diagnosis, treat the patient, and manage TMD using a method. And what sets this training apart? It wasn't developed in an isolated academic laboratory. It was developed in a real clinic with practical application, scientific validation, and thousands of cases in different settings, regions, and countries with students from Brazil and abroad. You don't need to change your specialty. You integrate the method into your specialty, Orthodontists applying it, periodontists applying it, rehabilitators, general practitioners, all of them are using the methodology because the method supports your practice. It doesn't replace it. And the applicability is immediate. Within the first pillar, you receive a consultation structure, a script for closing the exam, organization of the plan by intensity, a logical sequence for care, and a model for clinical reasoning. You don't just leave with information, you leave with direction. And then the second pillar of SIBX is clinical and functional expansion. After you master the foundation of the DTC method, you don't stop, you expand. The second pillar consists of complementary training programs organized into independent modules that delve deeper into the subject area. How, Andrea? Specific areas related to bruxism and functional dentistry. These training courses are not mandatory for you to start. They are strategic for your development. You access it as your clinical reality requires. So, for example, training 1, advancement plates for snoring and apnea. Sleep dentistry applied with clinical criteria. What does this training actually do? It takes you out of insecurity, puts you into sleep dentistry with clear boundaries, teaches you how to work as part of a team, gives you criteria, and most importantly, shows you that you are not encroaching on the medical field, but rather working together, competently practicing dentistry within interdisciplinary care. There is a real clinical opportunity. Let's talk about opportunity. Snoring and apnea are highly prevalent, and many patients do not want to use CPAP. They look for an alternative, and many doctors know that the oral advancement device is very well indicated in mild and initially moderate cases, and this is where you come in. When you master this training, you expand your field of practice, increase your medical ticket or responsibility, strengthen your authority, add value to your consultation, and you stop treating only the consequence. You start to address the respiratory cause. This training reinforces something essential. You do not promise a cure. You do not replace other adjunct and adjuvant medical treatments. You work with the correct indication, with reports, with follow-up, with responsibility. This is not opportunism. On the contrary, it is modern dentistry, awareness, and structure. When you say, I work with bruxism associated with sleep-related respiratory disorders, the market changes. So you move up to another level. And the second training is crisis management of muscle issues in the clinic. This training was created to solve one of the most challenging situations in clinical practice. The patient who arrives in crisis with intense pain, limited mouth opening, incapacitating headache, pain radiating to the ear, temple, or neck, a sensation of jaw locking, clicking. At that moment, many dentists feel insecure. They may even know it could be muscular, but they don't master the structured protocol for diagnosis and intervention. And this training delivers exactly that. This increases confidence, patient loyalty, referrals, and perceived value. This well-structured management of muscular crises prevents rework and rehabilitation, reduces recurring fractures, improves adherence to bruxism treatment, increases the use of medical kits, and maintains integrity. And most importantly, you don't have to rely solely on a mouthguard. You begin to master protocols for managing pain crises and muscular treatment. Training 3 is about interpreting imaging exams with a strategic functional perspective. This is not a course for you to learn how to read imaging exam reports. It's a training for you to stop relying exclusively on the report because there is a real problem in clinical practice. The report describes the anatomy, what the patient is presenting at that moment, but it's you who decides the course of action. And many dentists receive reports, for example, from tomography or cephalometric exams, read the report and don't really know how to correlate it with the case, with the clinical case. And this is where insecurity comes in. This training was created to give you 3 fundamental steps: diagnostic confidence, decision-making criteria, and clinical protection, which is documentation. When you master the functional reading of these imaging exams, cephalometric, MRI, tomography, your diagnosis becomes more precise, more solid, you gain depth, and your professional stance changes. You stop being just a technical dentist and become a strategic clinician. The last training in this complementary cycle is the 4th course: pediatric bruxism, early diagnosis, responsible intervention, and a family-oriented perspective. This is one of the most neglected areas in dentistry because many dentists believe that pediatric bruxism is normal, that pediatric bruxism is physiological, that it's normal and will go away on its own. It's not worth intervening or even investigating. Unfortunately, many believe this. In some cases, you really do have bruxism that will decrease as the child grows, but these are rare. In the vast majority of cases, we have breathing problems, routine issues, intervention, little sleep time, and worst of all, pediatric patients who are undergoing brain development where we see low nighttime breathing and childhood apnea. This child's brain is being limited by low oxygenation, and this training exists precisely for that, to provide criteria, safety, and a clear boundary between what is physiological, pathological, problematic, and not problematic. And when you master pediatric bruxism, you expand your authority with families, gain the trust of parents, follow the patient for years, strengthen the bond, increase natural recurrence, and bring a quality of life and development to this child that they would not have without your intervention. So you stop treating only adults who already have severe wear, for example, and start working on prevention and the development of the child. What does Pillar 2 actually do? It turns you into a well-rounded professional, while Pillar 1 organizes your foundation. Pillar 2 broadens your scope of practice, increases your average ticket, raises the perception of your authority, expands your referral network, and strengthens your regional positioning. But notice, you don't come here to study everything all at once. You come here to evolve. When you master these complementary trainings, you start to identify sleep apnea before other professionals, bringing health to your patient, a diagnosis they didn't know about. Managing muscle pain safely, recommending the advancement device with proper criteria and preparation, correlating imaging with function, working with both adults and children. This isn't about the amount of content, it's about depth of practice. And finally, I want to talk about the third pillar, which is control, community, and authority. What sustains your growth over 12 months and puts you in the new era of dentistry is the following decision: control, community, and authority. After you understand DTC and learn how to apply it in practice, there is a risk. You go back to your routine, rushing around, putting out fires. The method gets left halfway done. And with the third pillar, I created this to prevent you from going back to doing the same things now that you already know the methodology. It is the system that transforms knowledge into consistency, consistency into security, and security into authority. So consistency, security, authority. Here, I call this a movement. It's not about taking a course. It's about entering a new era of 360-degree dentistry beyond just teeth. So here we have updates and live support for 12 months. You will receive updates and live support for 12 months. One live meeting per month with mentors and guest speakers. A class with a Q&A session at the end, case studies and clinical decision-making, applied scientific updates. The goal, to keep you on track and prevent insecurity. What brings dentists down the most is the loneliness in the clinic. In this community environment, you will connect with other dentists who are applying the method, share case repertoires, exchange clinical perspectives, and feel that you are not the only one with that question, the feeling of belonging. This reduces fear and increases your action. It's much easier to break out of inertia when you're not alone. This is what turns Bruxism into a predictable schedule. There is a huge difference between I took a course and I am part of a society, the International Society of Bruxism. And when you join SIBX as a standard member, you don't just receive the content, you gain a professional society identity. You start to have an annual digital certification as an active member, institutional recognition within the ecosystem, changing your external narrative. You're not alone, you're connected to an institution, an international Bruxism society. And here's the strategic point. The patient doesn't understand technique, they understand trust. You communicate. I work with differential diagnosis. I am a member of the International Society of Bruxism. Perception changes. You stand out from the ordinary. This isn't empty marketing, it's positioning supported by structured training. And that's what I'm inviting you to. Now, let's talk about what supports your practical development throughout the year. Access to DP4, a free 30-day trial. What is DP4? What is it and why does it change your routine? DP4 is the 360-degree digital medical record with intelligence and clinical application. It's not just a regular form. It's an API developed to organize clinical data strategically. It generates automatic scores, Bruxism risk classification, guides diagnostic reasoning, creates a structured history, and even feeds a clinical dashboard so you have an operational tool within the DDC digital method. Why is it important? Because many dentists may know what to ask, but they don't know how to organize it. When you don't organize, you forget information, lose consistency, can't track progress, and don't generate comparative data. DP4 transforms anamnesis into digital clinical intelligence, showing how up-to-date you are and freeing you from loose papers, placing you within a structure where you can bring in digitized knowledge and a scientific basis. Through this data, we will increasingly build a more structured science. You will receive a standard ticket to Bruxism. What is Bruxism? It's an international convention that will take place this year, the International Bruxism Convention. It's not a generic event. It's a meeting exclusively focused on Bruxism, muscle pain, sleep, functional diagnosis, and 360-degree dentistry. It will bring together professors, mentors, doctors, specialists, and dentists who are applying the methodology. And why is it important? Because updating yourself can't be done in isolation. The in-person event creates immersion, connection, networking, case sharing, strengthening of identity, and practical updates. You stop being alone and you become part of an ecosystem. Participating in Bruxism strengthens your professional image, and you are no longer just the dentist who took an online course. You become part of a scientific and clinical movement that elevates your reputation. In addition to Bruxism and DP4, you will have access to the scientific blog and updates. You will receive evidence-based updates, scientific summaries, important literature reviews, content applied to clinical practice, and these scientific reviews will be posted on a scientific blog in accessible language. You don't have to rely on hearsay. You work with up-to-date science at your fingertips. You will receive this structured scientific blog. There's no need to spend hours searching for articles. I know you don't have time for that. The International Bruxism Society has a team of scientific mentors who do this for you, and you will have access to it. So it's an environment for discussing clinical cases, exchanging experiences, and networking among members. You stop being isolated, alone in your office. And in fact, what does this third pillar represent? It's not a bonus, it's a foundation. It's what keeps you from going back to a fragmented dentistry, the old way of thinking, the hyper-specialist view that doesn't see the patient as a whole. It's what keeps you in the new era of 360-degree dentistry. Okay, Andrea, I get it, I love it, but what is the investment amount? How much does it cost to look at your patient and not have the answer to what's wrong with them? How much does it cost when they ask, doctor, why is this one breaking? Why is my resin breaking? Why doesn't this pain go away? Why doesn't this sensitivity stop? Nothing solves it. Is this normal? And you don't have absolute certainty about what's happening. How much does it cost to have that feeling of leaving the room thinking you could have investigated better and brought results for that patient? Is there something behind it? I hope they don't come back worse, just hoping for the best. This insecurity might not show up on your bank statement, but it's heavy. Let me use a very simple analogy for you. Imagine a cardiologist who sees a patient with chest pain and decides to only treat the pain without investigating, without tests, without understanding the cause. He might relieve the symptom, but he doesn't solve the problem. Now imagine another doctor who investigates thoroughly, follows protocols, makes a definitive diagnosis, and provides structured follow-up. Which one would you trust? That's what 360-degree dentistry is. It's not about doing everything in a scattered way. It's about doing things with depth and structure. Now think about something simple. If you close one structured exam per month, one structured diagnostic exam per month, one well-explained treatment per quarter, every 3 months, you close one. That already changes your year. And not because you sold more, but because you manage things better. So the question isn't how much it costs to get started. The question is, how much does it cost to keep going without structure? How much does it cost to keep improvising? How much does it cost to just treat the effects of wear and tear? How much does it cost to leave the patient with restorations without being sure about them? How much does it cost to remain invisible? How much does it cost not to evolve? Because staying where you are also has a price. And the price of stagnation is usually higher than you think. Now I'm going to show you something in a very rational way. If you were to seek out a complete structure, a structured training in Bruxism, another in sleep apnea and mandibular advancement devices, another in muscle management, another in pediatric bruxism, an annual scientific update, digital tools, technological investments, in-person scientific events, congresses, a society with certification. If you did all of this separately, it would easily cost more than 10,000 Rs. But I didn't build this movement to be inaccessible. I built it to train dentists to go beyond just teeth. But the movement was not created to make knowledge elitist. That's not my goal. It was created to train a generation. It's not for the elite. It's so that everyone can have access. And that's why becoming a standard member of the International Society of Bruxism with a full year of access to all this structure, the investment will be $399. Will give you 12 months of access to the complete training. Bruxism from zero to advanced, advancement splints for snoring and apnea, intraoral devices, management of muscle crises, functional interpretation of imaging exams, pediatric bruxism, live updates with 12 classes, 1 per month live, a structured society, and the SIBX ecosystem, all without paying separately. It's all of this, $399. And how does the registration work, Andrea? What you are acquiring at this moment is a recurring annual subscription to SIBX Standard. What does that mean? You have 12 full months of access to all the training from Pillar 1, all the training from Pillar 2, Bruxism, all 5, and the entire ecosystem of Pillar 3 with the technology of the app, the exam, the form, the 360 digital, all live updates during the active period. And at the end of those 12 months, your subscription can be renewed so you can continue within the society. It is not a lifetime course. It is annual access with continuous updates because science evolves and you evolve along with it. If you already understand that you can't be left out, you can register simply and securely. So what happens now? Now a button has appeared down below. Click on this button and you will be directed to Hotmart's official payment page. There you will enter your information, choose the payment method, confirm the transaction, and that's it. As soon as the payment is approved, you will automatically receive in your email the confirmation of your registration, your login and password, immediate access to the platform, guidance to get started, everything automatic. No need to wait for manual contact, no bureaucracy. You can start today, right now, watch the first module today, and already apply the first step at your next appointment. The decision is yours. The button is right below. If you want to enter the new era of dentistry, click the button now, complete your registration, and I'll see you inside SIBX. If you better structure your plans and close one additional treatment this quarter, you're already multiplying. So it's not an expense. It's a structure for professional growth with a differential diagnosis like you've never seen in your life. The question isn't whether the price fits. The question is, do you want to stay in old school dentistry or do you want to fully enter 360-degree dentistry? Because the new era isn't about doing more. It's about doing better, doing it with a method. If you feel that you're ready now to join this movement, sign up right now. Don't put it off because the time is now. Opportunities pass by and you'll regret it if you let this one go. 3 possible paths, and I want you to make your choice very consciously. The first path is to close this page, go back to your routine, keep working the way you always have, keep addressing what seems to be the main complaint, and nothing changes. And that's okay. You won't make any further progress in the 360. Things will stay the same. The second option is to try to apply it on your own. You learned in this masterclass. You can search on Google. watch some random videos, keep following me, take disconnected courses, try to build your own structure, your own way of working. Maybe it will work, maybe it won't, and will take a while. Maybe it will create extra work. Maybe it will make you feel insecure and you'll be on your own. And it will take quite a while for things to actually work out in a structured way. And the chances of you giving up are huge. Now, your third option is to enter the new era with a methodology, to enter the new era of dentistry 360 degrees with a methodology. You can transform, you can make this decision now in a different way. By joining the International Society of Bruxism, you'll have structure, direction, an organized method, support, updates, an ecosystem, people by your side, 12 months of consistent growth starting now. Below, there is a button. Click on this button and you will be directed to Hotmart's secure page where you can choose payment by card in 12 installments of 197 or 1,997 in full by bank slip or Pix. Fill in your details and confirm the payment. Automatically, once your payment is confirmed, you will receive a confirmation, login, and password in your email with immediate access. It's that simple. The decision is very simple. Continue as you are, try it on your own, or join the method. I know which decision changed my path, and today, in more than 25 countries, there are over 2,000 members. Now it's your turn. If you want to be part of this new generation, this new era of dentistry, of dentists who go beyond just teeth, click the button below, and I'll see you on the inside.